Um, but anyhow, Ms. Wilson, if you are ready, we'll let you take on this
Yeah,
presentation.
I'm ready. Yeah, I got to sit in on most of your interviews over the past couple of days, and I was very impressed. I'm excited to see you guys succeed. My goal for today is just to help you do that with a few nuggets of, maybe some wisdom and test taking strategies. Just a little about myself. I'm a graduate student at JSU, and I want to thank Dr. Walker for the opportunity to get to precept here with Dr. Craven. I want to thank Dr. Craven and your class just for opening an ear to me, and hopefully I can get you to some success with the NCLEX. My goal is the same as yours. So we are going to talk about test-taking strategies, particularly prioritization, delegation, and select all that apply questions. So a lot of people wonder why the big deal about these types of questions. Well, on the NCLEX, guys, this is like 17 to 23% of your NCLEX. And in fact, your select all that apply could be as much as 33% of your test. So instead of being scared of these types of questions, we want to go in confident that we can answer them. So I want this to be an interactive time, okay? This is not going to be a lecture where you guys just sit back and, are bored. I really want some interaction. So if you don't mind, if y'all could turn your cameras on, it would help, because this is going to be very interactive with some open discussion. Oh, and I see lots of eye rolls. You didn't want your cameras on. Oh, man. Here comes Miss Wilson making me show my face. Thanks, guys. So just some interaction. I'm going to ask some questions, and if you want to raise your hand or go in the chat, obviously don't talk over each other, but I do want you to interact as much as we can in a Zoom setting. So somebody tell me, what are the challenges that you face with select all that apply? Somebody tell me. Somebody be brave.
Whenever I see a bunch of select all that apply options, I know the answer sometimes when I go into it, and then I read the answers and it makes me change my answer, because I'm like, it brings something up that I didn't think about, and then I second guess myself, and then I get it wrong. But then sometimes I get it right, and it's like, I don't know which is better.
Yeah, sure. Okay, anybody else?
I'll get 2 of the 3 right, or something like that. I get the majority of it right, and then I'm down to 1 or 2, or I talk myself into that there's got to be more than 2. There's, those kind of things, and do it that way.
Sure. Okay. What about delegation? What about delegation questions kind of throws you guys off?
For me, it's like the specific, like little details, the difference between the UAPs and the LPNs. Like there's a little bit difference, and like I'm usually pretty good on them, but then there's some questions where I'm like, can they do that? And I guess that's just reviewing and knowing for sure what can and can't be done.
Sure, knowing scopes of practice.
Sometimes for me, like also like on the delegation one, like say if you have 4 answers and one of them's like, what can LPN do? And it's like, one of the answers is maybe like walk the patient to the bathroom or help the patient do something. I'm like, well, that can be like a UAP. So I question, like, even though the UAP is not like in the question, and I know that like the LPN can't do the other 3 things, and I'm like questioning like, well, can they or can they not? And I second guess myself, because I'm like, that's something that someone lower on the chain can do. Sure. So why would they put that for the LPN? And it confuses me sometimes.
Yeah, sure. Okay, and that's very valid.
I feel like they also they word it just so. You really have to pay attention, because a lot of times they won't use the word teach. They'll use a different word, but it means the same thing, and they can't teach. They can reinforce teaching, but they can't teach. And there's just some words
that
you really words. Have to pay attention to. And a lot of times I don't notice the words.
Yeah. Slowing down and noticing the words is definitely important, because NCLEX is all about verbiage, guys. The term scope of practice and It really is all about learning what are they asking me in this question. So what about delegation questions? I'm sorry, I said that one. What about prioritization questions that throws you off?
Real life scenarios that from working in the hospital that confuse you with what they really, really want you to act like in a perfect world that'll never be perfect.
Yeah, 100%. That, and for me on NCLEX, I mean, guys, I graduated 10 years ago, but I still remember NCLEX prep, and I was that student. I remember my first semester, Dr. Craven was actually my teacher, and I went into her class with a 4.0, and my first test with her, I think I made a 76, and I cried and sobbed and argued. And then my point is, you have to learn to take the NCLEX questions for what they are. And especially if you've been working in the field and once you've been doing clinical, you have to disconnect, because these are NCLEX patients. They're not real patients. They're NCLEX patients. And NCLEX is trying to ask you something specific. But if you add all of your experience into that question, you're going to start assuming things, putting things in there that are not there. So Joey, you're exactly right. You kind of have to disconnect and don't add to what is there. This is an NCLEX question. This is not what I actually did at work. Because here's the thing, with these prioritization questions that say like, which patient would you see first? You guys are experienced enough. If you've made it this far, I am confident if you were in that situation, you'd go to the right patient first. You'd know, you'd feel it innately. But when it's on paper, sometimes it's hard to not overthink it. But I know you guys have these skills. So hopefully, as we go on, we can get a little help as far as how to answer these questions. So let's go to the next slide, Dr. Craven, with the learning objectives.
Whoop, sorry.
Oh, you're good. So, you know, this is kind of my goal for the day. Just so you know what we're going to do. We are going to take a pre-quiz here in just a minute with some of these questions. We're going to come back. We're going to do a couple case studies, but we're going to do a thorough quiz review so that we can actually discuss the rationales. And again, my goals are the same as your goals. Pass NCLEX, okay? So at this time, I want you guys, if you can, open up Blackboard in another tab. And you're going to have a pre-quiz that is loaded on Blackboard. If you go under contents, it'll say pre-quiz. You will have 15 minutes to take this quiz. It's 9 questions, so you got 3 of each. And you're going to have 15 minutes. I think, and Dr. Craven, we're going to do some breakout, no, I'm sorry. We're just going to let them go. Tell me how this is going to work, Dr. Craven. The best of. Oh, you're muted.
Sorry.
That's okay. There you are.
Sorry. Y'all will go ahead and go into Blackboard. You'll take your quiz, come back in 15 minutes. We're going to divide up into some groups, and Ms. Wilson will continue the discussion, and she'll share with you when we come back in. We'll all be in here for a little bit, and then we'll break out, but I'll put you in breakout groups. They're just randomly assigned for you guys. So, and when we get through in about 15 minutes, let's come back at, let's see, can we come back at 9:30? That should give everybody time. Just come back into this main room. I know some of you, when you switch over, your cameras will turn off. So that's fine. But you just got those 9 questions. We'll come back in again at 9:30, and we'll meet you back in here.
Where is it on the Blackboard though? You said content?
Go under content.
Mm-hmm.
Okay.
Roll all the way down.
The bottom page, maternal PED review.
Hold on one sec. Go to content. You may be able to see a follow along on me. Go to the bottom where it says pre-quiz. My bad. I apologize. Let me make this available. I apologize. Please forgive me. Let me make that available for you guys.
There we go.
All right. If you'll refresh, you should see it under content.
Here we go.
Not enough coffee for me this morning, and I apologize. So, all right. We'll see you at 9:30.
All right.
All right, Miss Wilson, I think everybody's kind of come back in. I'm not sure. Let's see. Everybody should be back in big room. I see no, not everybody's back in. So let me just double check.
Okay.
All right.
Okay. Trickling in.
Yep.
For those of you who are here, how was that? Good, bad, hate it, loved it.
A little aggravated.
A little aggravated.
Who else? Anybody else
Anybody else?
thought it was good?
I felt like I done great until I seen the correct number at the end of it, and I was like, ew, ew.
Okay. And we're going to go over that. And that's the
Yes.
purpose of today, really just to try to help everybody.
Yeah, with just a few questions just to dissect them. Okay. Dr. Craven, we want to go ahead and get started?
Yeah, I think so.
Okay.
Everybody should be back.
Heather said that her and Lisa were in the breakout room. I just texted her back and said to go back to the main room.
Okay. We'll go to those breakout rooms in just a minute. So I'll just go ahead and jump in. The next slide we have is some test taking strategies. If I was you, I would take a picture of this slide on your phone because I'm going to talk about it. But you know, these are some just 5 little strategies that if you can learn to apply these with every question, I think it'll help decrease your anxiety tremendously. So just to talk about the first one. Okay. Always read the entire question, then think about the content. So let's say you had a question about, and it asked you about a patient with hemophilia A. Our anxiety will want us to go ahead and we're going to jump to the answers and we're going to look over the answers and then we'll try to answer it. So I'm going to encourage you slow down, take that question and say, okay, what do I know about hemophilia A? Go over it in your head, review the information, then look at your answers. So often with testing anxiety, that we want to jump ahead, but if you'll slow down, go ahead and get in your mind, okay, this is what I know about CHF. This is what I know about heparin. This is what you see what I'm saying? So that's a good strategy. Next, we have tell yourself what you think the answer should be prior to looking at the answers. That way, when you go look at the answers, you found it because you already thought of the answer in your head without having to be prompted. Because often those answers that are available, there's some of them that are distracting. There are some of them that are meant to sort of confuse and maybe make you think you're thinking about something else. So go ahead and answer it before you look ahead to the answers. Next, we have, so look over the answers and always ask yourself, does my answer reflect what the question is asking me? Because sometimes you may give a really great answer, but it doesn't exactly apply to what the question is asking. For example, If the question is asking about a COPD patient with shortness of breath, and you immediately picked an answer that said, give them Lasix, go back and ask yourself, okay, does my answer of giving Lasix really apply to the shortness of breath of a COPD patient? And you may catch yourself and realize, oh no, that's probably CHF with the Lasix. So next, I said for select all that apply, treat each answer as if it is part of a regular question with one answer. Then ask yourself, if this was a regular question, would I select this answer? And if you would, then move on to the next answer. We could have a select all that apply that had 25 options. That sounds incredibly daunting, but it's the same process regardless of how many options are available. The select all that apply, take them one by one and ask yourself, is this a correct answer to this question? And then move on. So lastly, I said prioritization. What could happen in room A if I went to room C first? So with those prioritization of which patient is more important, which would I see first, you're always going to want to go to the one that is at the most risk for something bad happening in the next few minutes. Okay. So for example, if I'm a nurse and my option A is to go see Dr. Craven with her 9 out of 10 pain, but option D is go see Elizabeth who's having some shortness of breath. If I choose to go see Dr. Craven to give her some Demerol for her pain, what's going to happen if she starts talking and she's telling me about her life, and then she starts crying about her grandfather, and then I'm stuck in that room? What could happen to Elizabeth in that 15 minutes I've been in there with Dr. Craven? You see what I'm saying? Does that make sense? Anybody? Anybody make sense? Okay, I see some nods. All right, good deal. Yeah, I want you guys to be interactive because I can't help you if you don't say something.
Are we supposed to be joining the breakout rooms? Because I know when I did on my computer, it knocked me out of this room. So that's why I logged into this Zoom on my phone. But now it's inviting me into a breakout room again. I'm afraid it's going to knock me out because I am not, like, I missed part of the beginning of this.
You're
Hey,
good.
Jenna, that's Heather.
That's
Sorry, Heather. You'll go into your breakout room and then you can come back in. I'll readmit you into the big room. You're fine.
Yeah, we're about to go to breakout rooms. So, yeah, no worries, Heather. You're good.
Sorry.
Okay, so our next little activity, we are going to go into the breakout rooms that we've created for you. We're going to work on a case study as a group, okay? So let's see. Let's go to, I want y'all to get out your phones or take some notes. We're going to give you a couple of slides. The first slide we'll have on it, each group is to discuss the following. And these are the points we want you guys to hit. So if you got your phone ready. When you've got it, if you don't mind, just give me a thumbs up in the screen so I can see you're ready. Okay. All right, so now we'll go to the next slide. So here's your case study. You can take a picture of this one as well, and I'll read it to you. So a 62-year-old male was admitted with cirrhosis and a DVT. Client reveals a history of DVTs and hepatitis C. The physician has ordered home medications to be continued. The client revealed he takes lactulose 15 milliliter daily, warfarin 10 milligram daily, aldactone 75 milligrams daily, Tylenol is needed, and Imodium is needed. The physician has ordered a liver biopsy, an EGD, labs, and a regular diet. Labs reveal ALT 120, AST 85, ammonia 55, albumin 3.1, PT 28, and INR 3.5. Okay. All right, guys. So Dr. Craven, are we ready for them to go to their breakout rooms?
They are. They can go ahead and go into their breakout rooms. You should have received an invite, so you can go to that breakout room. and you'll discuss that case scenario, and you're going to respond to the questions that Ms. Wilson provided in the previous slide. So we want you to go and discuss. Everybody in the group has got to participate, and we'll jump in throughout the rooms and check on you. If you've got a question, just let us know.
And guys, when we come back, be ready to discuss. I'm not doing this to be mean, but I don't know you very well, so I don't know who talks and who doesn't normally in class. So I'm just going to probably pick randomly. Hey, Jennifer, what did your group say? Okay, so everybody be ready, be involved to answer these questions. Okay, let's see, it's 9:40. So what about 10:15, Dr. Craven? Do you think that's sufficient?
Sounds good.
Okay, all right, guys. Well, we'll see you back in this room at 10:15.
Indicated, and you can do his medicines.
Yeah, I think that's good.
The select all.
Yeah.
It doesn't say like one way or another, I don't think. Let me look. I would also say, I don't know if this will be asked or not, but I think that it's appropriate to keep him on bed rest since he does have DVT, because you don't want him up walking around and doing whatever, right?
That's true.
Do you not want them walking around, or do you? Because the compression stockings is meant to help blood flow. Walking around helps blood flow. Because what a DVT is like a blood clot. So
Yeah, because I thought Dr. Bonds always said that you didn't want them walking around and everything, because if it breaks off, you don't know where it would go.
oh,
And then it could cause a bigger problem.
gotcha.
I mean, correct me if I'm wrong, but I think that's what I remember.
Look, I'm like you, girl. I'm like over here. Let me ask a stupid question real quick, okay? The struggle is real.
Right. I feel like we've learned so much, and I'm like,
I know. It all starts to run together.
right. Okay. So you said for the select all that apply, you would just say which medications are contraindicated and then list all of them, correct?
Yeah, this is what I put. 62-year-old male patient admitted with cirrhosis is scheduled for a liver biopsy. Which scheduled medication would be contraindicated or
Okay, and so our other one's a prioritization. Okay, so which patient first? Or what?
I think.
What would you do for, we could do like,
Oh, did y'all see that? It appears we need to extend the time, so we have until 10:30.
oh, great. Good. Okay. So prioritization. Let's see here. What if this patient suddenly had breathing issues or what? Or started looking restless and the heart rate went up and
That
no,
could, so what could happen to him because of hypokalemia?
cardiac issues.
Yeah.
So if he started having signs of hyperkalemia, that would be a priority over
Or two.
well,
We got to come up with a question though. Does that, I guess it has to be about this patient, right? So let's see.
That's what I don't understand how to do it, because usually the prioritization one,
Different.
you have like 4 patients.
Yeah. Yeah. Let's just make, on the prioritization, which would you see first? I mean, and then let's just use our patient now would be what?
Well, we can
Deep-
use some of his information, like we can
Yeah.
say,
well, I say which patient we see first. Will we see our patient before we saw somebody with a compromised airway? No. Would we see our patient with these labs before we saw a diabetic patient that had a blood glucose of 120? We would see our guy first. Who do we want to see first? Who do we want to make our patient that we're going to see first? Our guy or a different patient?
I guess it's fine.
All right, we got it all. It looks like. Also, there's something else that we had to go more in depth for.
Questions?
Huh?
What we have to go more in depth for?
I said, is there anything that we had to go more in depth for? I feel like we got everything.
I think we did too. Are we ready to be able to talk about it all individually?
Okay. Well, I guess I'll go chill until 15 more minutes.
Just send me your notes, please, Anna.
All right, yeah.
Okay.
I will right now.
Do we press leave room?
Yeah.
Well, if they take them off to, like, let's say bathe a patient, they have to be able to put them back
They
on.
have to put them back on.
Yeah. Well, okay, so
Well, I know the UAP can do things with their order because, like, my son, he's a tech, which is technically a UAP, and they do like straight sticks for like blood draws, and those are ordered.
Okay.
that's true.
They just can't initiate IVs.
We could do something about a med.
Yeah.
Yeah, do something like a PO med because that's like, oh yeah, of course I can give them.
Gives the warfarin.
Isn't it lactulose?
Lactulose.
Isn't that what it had?
I don't know. I know the warfarin was.
Was it? Okay, we can
Do the warfarin.
yeah. So the UAP gives the PO warfarin or the patient. I don't know how to word things. That's English isn't my strong suit. The UAP gives the
order dose of warfarin. PO.
okay.
We have to do a prioritization question too.
You're kidding me. Okay.
I always like the one that says the patient is satting 86% on room air. You know, what would you do first? I always pick oxygen because it's like a gimme answer, I think.
Well, yeah, airway, breathing, circulation, which is interesting because I always think like airway and breathing looks like the same thing.
Yeah. I don't really understand the difference, I guess.
Like obviously if your airway is obstructed, you're gonna have a problem with breathing. But I mean, technically, you could have a problem with breathing and your airway is not necessarily obstructed.
Yeah.
That's why they changed it to CAB instead of ABCs.
Isn't that just for resuscitation though?
Yeah.
Okay, prioritization question. Which finding most concerns the nurse?
Okay, we like that.
Easier because they always give them a bath or ambulate.
Yeah. Let's see.
Hey, you good? You gonna change your shirt? Yeah, it's downstairs, right? Okay. Good luck. Have a good day. Do you need some money? What do you mean it doesn't matter? In my wallet? I think it's in the truck. Oh, hang on. Sorry, guys. I forgot to.
No. Did you find one, Autumn?
I did. Let's see. It's off Quizlet.
That's where mine's off of.
I mean, we're still learning, so it's hard for us to come up with our own questions because we still don't know.
If they get mad, oh well.
I may change it up a little bit.
Shoot, I didn't. I'm going with this. I just want to study. I feel like all these wasted assignments and busy work, I just want to study and pass NCLEX.
Yeah. Me too.
Unmute yourself, Mom.
I did.
Are y'all going to get UWorld? I'm thinking about purchasing UWorld at the beginning of next month, so it'll last me through May, just because I want to ensure that I pass this test.
I don't know. I'm not sure. I just got to get through the semester.
I just lost my page. Where's the
caring for a patient?
Okay, I don't know what I was thinking. I swear I just seen a flashcard with a cirrhosis patient, but that's something else. Oh my gosh.
What do you think about the exercise? Ms. Wilson will join us in just a minute, but I want to take a quick second to pop in and just ask what you were thinking about the exercise. How many of you felt comfortable with that little scenario? Or did you feel like you didn't know something about it?
Yeah, it
Feel
took
like
some review.
helped us, talking it through. I may have knew something that, one of them didn't know, and like Tasha may have knew something that I didn't know, or vice versa, and I feel like it really helped us all think through the process, us talking through it together as a group.
Mm-hmm. So if we could do that on NCLEX, So if we could do that on NCLEX, that would be awesome. We'd have collective powers. So I hope that you found that little activity eye-opening. I think it's always nice to see the course from fresh eyes and see where we are. So I just want to take an opportunity to share with you that the activities are designed to improve your outcomes on NCLEX. Everything we're doing this semester is designed to prepare you for NCLEX and to make you, not just NCLEX, to prepare you to be a competent nurse when you step out on that floor. So the activity you just did, we may not know everything about a disease process or a complication, but it is in our scope of practice to recognize our weaknesses, figure them out, use the resources we have. And so I want you to know that it's many times when you come across these things, you've got to stop, look, and listen. Stop what I'm doing. Listen, what I don't know. Like, I can't make these things up. I've got to take care of my patient. Listen to another nurse, ask them, but you have a resource in your hand most of the time where you can look something up. If you don't understand a medicine, you don't know side effects, you're responsible for knowing it if you're giving it or if your patient's on it. Look it up. If you don't know the disease process, look it up. We are not all knowing. There are many times we walk into units and we don't know the disease process or we don't know a medication. I can tell you to be successful on NCLEX, you're going to have a basic knowledge of disease processes. And so medicines come with that. You may not know that medication, but through process of elimination, you can decipher something about the disease process, something about medications. Honestly, I get a little concerned at this point in the semester when I don't see test improvement or numbers increasing. So today was a really good opportunity to evaluate test questioning, how we're responding to test questions before we get ready for this big CATS, because it'll give you a real good indicator of, I think it does a very good job, the correlation does with NCLEX preparation and success on NCLEX. And that comes from the statistics that are provided. That also comes from the weekly tests that we are doing. So if you are still struggling with getting in a certain percentage on test, if you are struggling to get up to par on those tests, think about it, because you need to sit down and meet with us independently. We have looked at plans. I need to hear from you what your thoughts are on your test taking strategies. There's a lot of resources out there. There's ATI, there's additional Kaplan prep, there's Hearst, there's UWorld, there's a Nurse Share, there's multiple resources. But if it's content that you're lacking or you don't understand, it doesn't matter what you spend on resources until you gain that knowledge of content. You have ample test questions to prepare you over this course or this semester especially. So if you are continuing, as I do, and I'm looking at your testing consistently, and where I see weaknesses, I would encourage you to really stop and evaluate what it is that you're identifying as your weakness, because I can clearly see some of the content from this side. However, even though I see it, you need to recognize that it is a weakness. So I just encourage you to really evaluate the test information that you are given through Kaplan, where your weaknesses and strengths lie. And I want you to look at your testing plan that you've got laid out. Right now, we're almost at midterm. If you've identified 6 or 8 topics that you feel like you consistently need help on, then stop, take a weekend, take next week, and really hone in on those areas so you don't continually make a lower score in those areas. So while I can look at my side, the testing, the evaluation from the perspective of results, things like that, I need you to let us know independently where you think you are, where you need the most help. We are here to support you. And we want you to be successful. But right now, much of this, the rest of the semester is you've got to identify where your weaknesses lie. And every activity is designed for you to be a successful nurse, pass NCLEX, but also you have a responsibility to the profession as you step into it, to be accountable for your actions, to be knowledgeable. And along with RN comes a lot of responsibility. So just recognize it is not all about that final exam. It is, we have to be successful, but it is the other things that we learn along with this semester. I've had a couple of conversations with preceptors, all good reports. Just ownership of things and responsibility has been a message that's been echoed. So take your learning and just recognize that we don't know everything. Let them give you feedback. Get them to help you improve. Ask them questions. Every opportunity presents another opportunity to learn or to build on a question and pass NCLEX. I'm going to let Ms. Wilson take over lecture again. We're going to go over your test. We're going to go over your responses to the breakout sessions. So everybody please participate. And I think, Ms. Wilson, you go ahead and I'll jump in with stats or anything else you need.
Okay, sounds good. Well, let's go over the case study first. So you guys, some of you mentioned you had to refresh, you had to go back and kind of remember. And just to echo what Dr. Craven said, guys, the world of knowledge that nursing can have is huge. And in fact, I was kind of eavesdropping on some different groups. One person said, we've learned so much that it all just seems to run together. Guys, that's real. This is a lot of information. But again, for NCLEX prep, it expects you to have a base knowledge, but so much of how you're going to learn to be good nurses is going to be on the job. For example, I've been a nurse 10 years, but if you put me in a pediatric setting, I would have to go back and relearn so much. So for NCLEX, we give you enough to pass NCLEX. But then when you really hone your skills, in your profession later, you're gonna really be able to hone in that knowledge on what applies to your particular choice of job. So, all right. So let's go back to this discussion. Okay, so we'll go with group 1. Let's talk about the orders. Were they appropriate or not?
Yes, ma'am. For the most part, yes. I think we had one, and correct me if I'm wrong, Anna or Austin, but I'm pretty sure we just had one, which was the diet that was inappropriate.
Okay. Bane, why was the diet inappropriate?
Well, with this cirrhosis patient, it said that he was needed a regular diet, which for the most part, yes, he does, but he needs lowered salt intake as well.
Okay.
because it can cause ascites with like liver and cirrhosis patients, and it didn't refer back to anything related to the salt intake. And then his protein was low as well, based off of the labs. But also they shouldn't have too much protein in their diet either. So it's like, it just didn't reference it. So I thought I should talk about it.
Okay. Yes. Very good. So the diet was incorrect. It does need to be a low protein, low sodium diet. Okay. Anybody else? What other groups? Group 2. Did you have any orders that maybe you would question?
Were we group 2? I didn't actually pay attention to the number.
It was Elizabeth. Group 2 was Brian, Danielle, and Elizabeth. Yes, you're 2.
Okay. So we wanted to, we saw that their PT and INR was high for a therapeutic range.
Okay.
And so we wanted to question the orders for the biopsy and the EGD, maybe holding off on those.
Okay.
Bleeding could get like back to a normal level.
Yeah.
Risk of bleeding out if we did those procedures right now.
Okay. Let's talk about the biopsy for a second. So why do you do a liver biopsy? What does it tell the doctor?
As to what conditions.
Okay. So we've already established that this patient has cirrhosis. So what I wanted you to get out of that is why would we need to do another biopsy? The risk of bleeding would far outweigh the benefits of having another biopsy just to see how the cirrhosis has or has not progressed. So the liver biopsy really is an unnecessary procedure for this patient. So tell me, Elizabeth, go ahead and elaborate a little bit more about the risk for bleeding that you mentioned with the labs.
Well, just as a patient with cirrhosis, he's already going to be at risk for bleeding because of the role of the liver in the clotting.
Right. But why is this patient more at risk for bleeding?
It's because he's on warfarin and he's outside of the therapeutic range, which is 2 to 3 with warfarin.
Yeah, that's exactly right.
We also questioned the Tylenol because of the effect on the liver.
Okay.
And we also talked about the diet as well.
Okay. Very good. Now here's a little thing about Tylenol. And I've always done this too. I've always gone, Tylenol is a no-no for liver. But in practice, just so you know, Tylenol can be given PRN because if you've got liver disease, every medication is hard on you. Every medication is a risk for toxicity. But with Tylenol, often that is in moderation, small doses, under the supervision of a physician. So for patient education, you wanted to make sure they were discussing with their physician their limit of how much they could have every day. But those are, yes, very good question to question that. Any other orders that you would question? Anybody? Chime in.
We said the lactulose, that it was on a low dose side, that it could go 15 to 30 mLs. And so that if, at 55, he was 10 points over what a high ammonia level would be. So that the lactulose every day probably shouldn't be every day. It probably should be for a limited time.
Yeah.
Until he gets him back in the range. And it's on on the low side of that. So if you would sort of almost think, well, you'd want to go ahead and get it down real quick before he starts getting delirious and, hallucinate and all that kind of junk. And then also on the warfarin, we said that the 10 milligram was too much of a dose for a daily deal, that usually a daily dose is more like a 5 milligram side instead of the 10. He was at 3.5, so the therapeutic range of INR was 1 to 2. So maybe for a minute, for a little bit to get it back in range and then go back.
Okay, so with the warfarin, the doctor said, let's go ahead and continue home meds, but our PT and our INR are elevated. So yes, we would certainly question that with the doctor. In most facilities, they do have, they have a flow sheet. They have a protocol. If, and it's, if their INR is this high, we're going to hold the dose for 1 day to decrease. So yes, we would question that because he's already high. Now, I will say it's different from patient to patient. It's also different between warfarin and Coumadin, which is the same thing. It's just generic versus the brand name, but different people react different ways. So there are people that are on 10 a day. The important thing about warfarin and Coumadin is not so much about the dosage as it is about the PT-INR. But yes, you're right. In the hospital setting, we would question why we would start that. Now, there's one other home med that I want y'all to pick up on.
We were questioning the Imodium with the lactulose because they're both for diarrhea.
They're
Okay.
counteracting each other is what we,
That's exactly right. The thing is, we want this patient to poop. We want the lactulose because we've got to get rid of that ammonia or we are at risk for encephalopathy. So yes, the Imodium, why would the physician write to continue that? And this is a real life thing. Working in the hospital, a lot of times the MD will just come and say, start home meds. And you really will have to go through them and say, do we really need to do that? But yes, Imodium was the other one. Good job, guys. Good job. Okay, so any other lab results? Let's say group 3. Which group was group 3, Dr. Craven?
Group 3 was Miss Jordan, Harris, and Fallon.
Okay, so group 3, what other lab results were you thinking about?
We kind of looked at the albumin level being low.
Okay, what about it? What do you know about liver and albumin being low?
you expect it.
You do expect it. That is an expected finding. What about the liver enzymes? Group 3. I want a little more from you guys.
The liver enzymes, the AST and the ALT, were both elevated. The normal range I found on the AST was 10 to 40. Our patient had an 85. And ALT, I found normals were 7 to 56, and our patient had one of 120. So both of those were elevated.
Okay. Are we going to be overly concerned about that?
I would think it would be kind of expected with the diagnosis that the patient has.
That's exactly right. That is an expected finding. It's not one we need to notify the doctor because he knows we have cirrhosis going on. So very good.
And we found out that too, we're in group 4, but we found out too that the elevated ALT and AST was expected with Hep C also.
Mm-hmm. Okay. Anything more about the PT-INR we need to think about? We've kind of covered that one, but did anybody else think about the PT-INR anything more than we've discussed?
At this point, would you administer vitamin K or would you hold off on the warfarin?
We're going to hold off because that level, though it is elevated, it's not considered warfarin toxicity. I think until the INR is about 8 and again, that's facility to facility. They have different protocols for that, but this is just considered elevated. I will say from experience work in home health, often we will get patients that the doctor just wants us to check their PT-INR weekly until they find their right dose. And so what we would do typically with those numbers is we're going to hold the warfarin for 2 days, then restart them on maybe a 8 milligram instead of a 10 and kind of tweak it from there. So, okay.
We found also that a lab that wasn't on here, but with the aldocterone, with it being potassium sparing, that we'd probably want to monitor that lab to make sure that we weren't building up our potassium.
Yeah, absolutely. Yes. If this was actually our patient, we would certainly be monitoring that. Very good. Okay, group 4. Somebody talk to me about your teaching and your plan of care for this client. Dr. Craven, who's group 4?
Group 4 is Jennifer Gann, Kayla Dawson,
Me, Joey.
and Joey.
We would teach on the diet, low fat, low sugar, low calorie, lean protein, high fiber, fruits and veggies, no alcohol, no coffee because of the DVTs, alcohol obviously because of the liver. And then the diet needs a liver, a liver friendly diet. Low fat, low calorie, low sugar, high fiber.
Okay.